Good evening, everybody. I'm Dr. Rohit Baijal, a consulting diabetologist, member of the European Association for the Study of Diabetes, European Society of Cardiology, and the American College of Physicians. I'm here to talk today on the cardiometabolic highlights of the year 2020. Today's presentation is intended for patients, for healthcare providers or doctors, and also from personnel from the pharmaceutical industry. The first part of the presentation is intended for both healthcare providers and patients, and the remaining part of the presentation is intended for both healthcare providers and members of the pharmaceutical industry. So let us start today's evening topic with USV CREST division on cardiometabolic highlights of the year. So patients with type 2 diabetes frequently have or are at risk of comorbidities. 60% of patients with heart failure and type 2 diabetes have chronic kidney disease. 35 to 45% of patients with heart failure have chronic kidney disease, and 20 to 44% of patients with type 2 diabetes have chronic kidney disease. So chronic kidney disease in presence or absence of type 2 diabetes has a staggering risk on our patients. 12 to 45% of patients with type 2 diabetes have heart failure. 8.7% of our Indian adult population have diabetes, and 32% of patients with type 2 diabetes have coronary artery disease. Now, type 2 diabetes and cardiovascular disease are both increasing. There is a common association between the two. Now, many remain asymptomatic or are subclinical, and there is increased morbidity and mortality due to a combination of type 2 diabetes and cardiovascular disease. Two-thirds of the deaths are attributable purely due to cardiovascular disease. So why are people with diabetes at increased risk for cardiovascular disease? So we come to the Asian Indian phenotype. Now, Asian Indians have a great ethnic susceptibility and genetic familial aggregation of type 2 diabetes. Asian Indians have a low birth weight, or they are popularly called thin fat Indians. There is increased inflammatory markers, especially C-reactive proteins, increased abdominal adiposity and visceral fat or visceral adiposity, decreased levels of adiponectin, characteristic dyslipidemia like decreased HDL cholesterol, increased triglycerides, and increased small dense LDL cholesterol. There is increased insulin levels leading to insulin resistance, lower threshold for body mass index for diabetes, and a lower age at onset of type 2 diabetes. So there is increased prevalence of both type 2 diabetes and a premature cardiovascular disease. Now, prevention of complications includes achieving metabolic targets like HbA1c, systolic blood pressure, body mass index, and lipid levels, especially serum cholesterol, non-HDL cholesterol, and LDL cholesterol. Preventing complications also includes both microvascular and macrovascular complications, preferably without hypoglycemia and weight gain. So agents capable of reducing complications. Now, microvascular complications, as we know, include retinopathy, nephropathy, and neuropathy. Now, nephropathy, like new onset or persistent macroalbuminuria or overt macroalbuminuria, which leads to end-stage renal disease and finally renal death. So we should individualize our HbA1c targets according to the international guidelines like the ADA or the AACE, and use drugs like SGLT2 inhibitors, especially canagliflozin or dapagliflozin, which have been documented in the renal outcome studies like the Credence study of canagliflozin and the Darpa CKD study of dapagliflozin. Macrovascular complications include myocardial infarction, stroke, cardiovascular death, heart failure, ischemic heart disease, or a peripheral vascular disease. Now, drugs used for reducing myocardial infarction include GLP-1 receptor agonists, which have been documented in the LEADER, Harmony, Rewind, and the Sustain 6 trial of liraglutide, albiglutide, dulaglutide, and injectable semaglutide. Drugs used to reduce stroke are glitazones, especially pioglitazone. Drugs used to reduce both cardiovascular death and hospitalization for heart failure are hands down SGLT2 inhibitors like empagliflozin, dapagliflozin, and canagliflozin, which have been documented in their cardiovascular outcome trials like CANVAS, DECLARE, Darpa Hf, and the EMPERIC outcome studies. And we have something very interesting for ischemic heart disease and peripheral vascular disease. Drugs like NOACs or novel oral anticoagulants, or how they are popularly called DOACs or direct oral anticoagulants like rivaroxaban, apixaban, dabigatran, and edoxaban. India has three of the NOACs available, like rivaroxaban, dabigatran, and apixaban. Edoxaban is not available in India so far. So let us see something very interesting for both patients and for healthcare providers. The No Diabetes by Heart initiative, which was a very elegant program, which was rolled out by a joint venture between the American Diabetes Association and the American Heart Association last year in the ADA and the AHA virtual conferences in June and in November. So let us see something more about No Diabetes by Heart. Ultimately, we're talking about diabetes and heart correlation in today's topic. So comprehensive cardiometabolic health management model for persons with type 2 diabetes, or life's simple 7 measures according to the No Diabetes by Heart initiative by ADA and AHA. 1. Measure height, weight, waist circumference. Now, calculating body mass index is recommended annually or more frequently to identify adults with overweight and obesity. For weight loss considerations, it is reasonable to measure waist circumference to identify those at higher cardiometabolic risk. 2. Measure blood pressure. Non-pharmacological interventions are recommended for all adults with elevated blood pressure or hypertension and cardiovascular disease. For those requiring pharmacological therapy, the target blood pressure should generally be less than 130 by 80 millimeters of mercury. 3. Measure HbA1c. Now, for adults with type 2 diabetes, lifestyle changes such as improving dietary habits and achieving exercise recommendations are crucial. If the medication is indicated, metformin is the first line therapy, followed by considerations of either an SGLT2 inhibitor or a GLP-1 receptor agonist. 4. Measure lipid levels. Now, statin therapy is the first line treatment for primary atherosclerotic cardiovascular disease prevention in those with diabetes who are between 40 to 75 years of age, patients with an elevated LDL cholesterol levels more than 190 milligrams per deciliter, and those at sufficient ASCVD risk following a clinician-patient risk discussion. 5. Assess tobacco use. Now, all adults should be assessed at every visit for tobacco use, and those who use tobacco should be assisted and strongly advised to quit. Now, referral to specialist is helpful for both behavioral modifications, nicotine replacement, and drug treatments. 6. Assess physical activity levels. Now, adults should engage in at least 150 minutes per week of accumulated moderate intensity or 75 minutes per week of vigorous intensity physical activity. And finally, 7, assess dietary patterns. All adults should consume a healthy diet that emphasizes the intake of fruits, vegetables, nuts, whole grains, lean vegetables, or animal proteins, and fish, and minimize the intake of trans fats, processed meats, refined carbohydrates, and sweetened beverages. So let us see the ASCBD risk calculator according to the No Diabetes by Heart initiative of ADA and AHA. Measure height, weight, and waist circumference. Measure blood pressure, especially systolic blood pressure. Medication use like antihypertensive, statins, and aspirin. Assess tobacco use. Measure age, sex, and race. Measure lipid levels and determine the diabetes status. Now, recommendations for statins and combination treatment in adults with diabetes according to the American Diabetes Association. Now, age less than 40 years without an ASCVD or a 10-year ASCVD risk more than 20%, no statin required. Now, presence of an ASCVD or 10-year ASCVD risk more than 20%. Now, high-risk patients with an ASCVD, if the LDL cholesterol is more than 70 milligrams per deciliter, despite maximally tolerated statin dose, consider adding an additional lipid-lowering therapy such as an ezetimibe or a PCSK9 inhibitor. Now, age more than 40 years without an ASCVD or a 10-year ASCVD risk more than 20%, moderate intensity statin therapy, presence of an ASCVD or a 10-year ASCVD risk more than 20%, in high risk patients with an ASCVD, if the LDL cholesterol is again more than 70 milligrams per deciliter, despite maximally tolerated statin dose, consider adding an additional LDL lowering therapy such as an ezetimibe or a PCSK9 inhibitor such as a alirocumab or an evolocumab. We do not have alirocumab in India by Sanofi. We do have evolocumab or Ripata, which was a research of Amgen Pharmaceuticals USA. They have a collaboration with Dr. Reddy's Laboratories India. So evolocumab or Ripata is very much available in India as of now. So let us see the decision cycle for a patient-centric glycemic management in type 2 diabetes according to the No Diabetes by Heart initiative. Now, goals of care include both prevention of complications and optimize the quality of life of your patient. So, assess key patient characteristics like current lifestyle, comorbidities like ASCVD, chronic kidney disease, heart failure, clinical characteristics like age, HbA1c height, issues such as motivation and depression, which are very important in today's time of the COVID pandemic. Cultural and socio-economic context is also paramount in today's time of the COVID pandemic. Consider specific factors that impact the choice of treatment, like individualizing the HbA1c targets, impact on the weight and hypoglycemia, side effect profile of medications, complexity of the regimen. Choose regimens to optimize adherence and persistence of your patients, and assess cost and availability of medications. Shared decision making to create a management plan between both the patient and the healthcare provider, which involves an educated and informed patient and also their family and caregivers. Seek patient preferences. Effective consultation includes motivational interviewing, goal setting, and shared decision making between both the patient and the healthcare provider. Empower your patient. Ensure access to a DSMES or a diabetes self-management education and support program. Now, agree on management plan like SMART goals or specific, measurable, achievable, and realistic and time limited plan for your patient. Implement the management plan of your patient. Now, patients not meeting goals generally should be seen at least every 3 months as long as the progress is being made. More frequent contact initially is often desirable for a diabetes self-management education and support program. Ongoing monitoring and support, including emotional well-being, check tolerability of medication, monitor the glycemic status, biofeedback, including self-monitoring of blood glucose, weight, step counts, HbA1c, blood pressure, and lipid levels. And finally, review and agree on the management plan of your patient, mutual agreement on the changes in a timely fashion to avoid clinical inertia. And finally, a decision cycle undertaken regularly at least once or twice a year between you, the patient, and your healthcare provider. So something which every patient should ask their healthcare provider according to the No Diabetes by Heart initiative of ADA and AHA when they go for a consultation. So these are the 4 questions every patient should ask their HCP about diabetes and their heart. 1, what can I do to lower my risk for heart disease and stroke? 2, do any of my medications help me manage my risk for heart disease or other complications? 3, are there problems that can help me manage my condition, and can you give me a referral to a specialist? And 4, how can I meet others going through my same experience? So if you, the patient, has type 2 diabetes, learning about your higher risk for heart disease and stroke is one of the best ways you can take care of yourself. So if you, the patient, wants to be a part of the No Diabetes by Heart, or if you, the healthcare provider, also wants to be a part of this initiative by ADA and AHA, you can simply log on to nodiabetesbyheart.org/join, and you can be a part of this great initiative by these two great bodies. The No Diabetes by Heart Initiative program by ADA and AHA is sponsored wholly by Boehringer Ingelheim, Eli Lilly, Novo Nordisk, Sanofi Diabetes, AstraZeneca, and Bayer. If you are interested as a healthcare provider, you can also get in touch with these pharmaceutical organizations to know more about No Diabetes by Heart program, or simply log on to the website of ADA or AHA and learn more about No Diabetes by Heart. Something very interesting about DSMES, or Diabetes Self-Management Education and Support. How will DSMES help you, the patient? When you learn that you have diabetes, the first question might be, what can I eat? Now, DSMES will answer this question and many others. Your first step should be, ask your doctor to refer you for a DSMES services. Now, if your doctor does not talk to you about these services, bring it up during your visit. DSMES services include a healthcare team who will teach you how to stay healthy and how to make what you learn a regular part of your life. DSMES services will also help you to make better decisions about your diabetes. Work with your healthcare team to get the support you need and understand how to take care of yourself and learn the skills to eat healthy, be active, check your blood glucose, take your medications, solve problems, cope with the emotional side of diabetes, which is very important again during this COVID pandemic, and reduce your risk of health problems. Something very important about DSMES. Now, people who have the knowledge and support to manage their diabetes are healthier than those who do not. Now, learning how to control your diabetes will save money and time and help you have fewer emergencies and hospital visits. Knowing how and when to take care of your medication, how to monitor your blood glucose, and how to take care of yourself helps you manage your diabetes better. Managing your diabetes will help you avoid or delay serious health complications like microvascular and macrovascular complications. Now, the skills you learn will help you take better care of yourself. Diabetes management starts with you, the patient. Now, it is important to go for a DSMES services when you first find out that you have diabetes, so you can learn how to take care of yourself. However, there are other times a DSMES can help you, the patient, better to learn about your diabetes. Now, when you first find out that you have diabetes, you may not know where to begin. DSMES can give you the information and support to start managing your diabetes. Now, during the early follow-up visits with your doctor, check on your progress and get help to prevent complications. Now, when new situations affect the way you take care of yourself, now new events or conditions in your life can affect your diabetes. Now, examples include diagnosis of a new health condition, a change in the mobility, depression, or money problems, which are paramount again in today's time of the COVID pandemic. And finally, when other life changes occur, the way you take care of yourself. So major life changes can affect your diabetes. Now, examples of life changes include a change in the living conditions, your doctor or insurance plan, and finally, very important, your job. Let's see some guideline recommendations. The American Association of Clinical Endocrinologists 2020 guidelines. Now, lifestyle therapy like risk stratification for diabetes complications, like nutrition, physical activity, sleep, behavioral support, and smoking cessation. Now, nutrition like maintaining an optimal weight, caloric restriction, plant based diets like high PUFA and MUFA, avoid trans fatty acids, limited saturated fatty acids and technological aids, and structured counseling or a meal replacement. Sleep about 6 to 8 hours per night, basic sleep hygiene, screen sleep disturbances and a home sleep study if indicated, and referral to a sleep study again if indicated. Behavioral support, very important in today's time of the COVID pandemic, community engagement, alcohol moderation. Discuss your mood with your healthcare provider, and formal behavioral therapy again if indicated. Now, complications-centric model for care of the patient with overweight or obesity. Step one, evaluation for complications and staging like cardiometabolic disease and biomechanical complications, which are further divided according to the body mass index less than or more than 25 kgs per meter square. A body mass index more than 25 kgs per meter square is again further divided according to the presence or absence of complications. Step two, select therapeutic targets for improvements in complications, treatment modalities, treatment intensified based on staging. Now, lifestyle therapy, physician counseling, remote or a web program, structured multidisciplinary program. Medical therapy, if the BMI is more than 27 kgs per meter square. Individualized care by selecting one of the following based on the efficacy, safety, and patient's clinical profile, like phentermine, orlistat, a combination of phentermine and topiramate extended release formulation. Lorcaserin is banned as of now because of the various side effects, and liraglutide or Saxenda, 3 milligram injections by Novo Nordisk in patients who are non-diabetics for overweight and obesity. Surgical therapy, if the BMI is more than 35 kgs per meter square, like endoscopic procedures, gastric binding, or a sleeve gastrectomy. And finally, step three, if the therapeutic targets for complications are not met, intensify lifestyle, medical, or surgical treatment modalities for greater weight loss. Obesity is a chronic progressive disease and requires commitment to long-term therapy and follow-up. Pre-diabetic algorithm, we will concentrate on treating hyperglycemia. If the fasting plasma glucose is more than 100 and the 2-hour postprandial plasma glucose is more than 140 milligrams per deciliter, if there is presence of one pre-diabetic criterion, intensify weight loss therapies. If there are multiple pre-diabetic criterion, low-risk medications like metformin or acarbose, or consider with caution glitazones like a pioglitazone or a GLP-1 receptor agonist if the hyperglycemia still persists. The ASCVD risk factor modification algorithm again will concentrate on dyslipidemia. Statin therapy, if the triglycerides are more than 500 milligrams per deciliter, or fibrates, or treatment grade omega-3 fatty acids, or even a niacin therapy. Now, if statin intolerant, try alternative statins, a lower statin dose or frequency, or add a non-statin LDL lowering therapy. Repeat lipid channels, assess adequacy, tolerance of therapy, intensify therapies to attain goals according to the risk levels. Now, the risk levels include high, very high, and extreme risk levels. Now, high risk levels like diabetes, but no other major risk, or an age less than 40 years of age. Very high risk like diabetes plus major ASCVD, risk like hypertension, low HDL cholesterol, smoking, and chronic kidney disease stage 3 or 4. Extreme high risk like diabetes plus an established clinical cardiovascular disease. Now, if not at desirable levels, intensify lifestyle therapy and consider additional therapy along with a good glycemic control. Now, if the triglycerides are between 135 to 499 milligrams per deciliter, add an icosapent ethyl 4 milligrams per day or Vasepa by Amarin Pharmaceuticals USA if the high ASCVD risk on maximally tolerated statins. Now, icosapent ethyl is the purest form of EPA or icosapentaenoic acid, which was researched by American Pharmaceuticals USA, and it has got a very elegant study called as a reduced IT study behind icosapent ethyl. And icosapent ethyl has also now been studied in the first human study in patients with COVID-19, which was presented in December 2020 in NLA, or the National Lipid Association virtual conference, with very positive results. Vasepa is very much available in the United States, and it's a great drug to be used in patients with very high triglyceride levels. Assess adequacy and tolerance of therapy with focused laboratory evaluations and even patient follow-ups. Glycemic control algorithm, individualized goals depending upon HbA1c less than or more than 6.5%. Now, HbA1c less than 7.5% as monotherapy, either metformin, a GLP-1 receptor agonist, SGLT2 inhibitors, or a DPP-4 inhibitor in the descending order. Now, independent of the glycemic control, if established ASCVD or high-risk chronic kidney disease stage 3, or a HFrEF or a heart failure with a reduced ejection fraction, start a long-acting GLP-1 receptor agonist like a dulaglutide or a semaglutide, or an SGLT2 inhibitor with a proven efficacy. Now, this is the profile of various anti-hyperglycemic medications, but we will concentrate on SGLT2 inhibitors. SGLT2 inhibitors are neutral on hypoglycemia. They do give rise to weight loss. They are not indicated with an EGFR less than 45 ml per minute, and they have potential chronic kidney disease benefits. Now, this EGFR level has now been revised to 30 ml per minute after the Credence trial of canagliflozin, which was presented in 2019 in the World Congress of Nephrology in Melbourne, Australia. And also after the recent Darpa CKD trial of dapagliflozin, which was presented in the European Society of Cardiology Digital Experience, and then subsequently in EASD Virtual Experience of September, again to 30 ml per minute. And just yesterday, this has been now recommended for dapagliflozin 10 milligrams per day with an EGFR less or equal to 30 ml per minute with a chronic kidney disease stage 3. So you can use dapagliflozin with a EGFR as low as 30 ml per minute now. And it's all thanks to the landmark Darpa CKD trial. SGLT2 inhibitors have neutral benefits or neutral effects on the gastrointestinal system. They do prevent hospitalization for heart failure. It was very elegantly seen in the Darpa Hf trial of dapagliflozin, and it has also been documented in the various cardiovascular outcome trials of SGLT2 inhibitors. They have neutral effects on the bone metabolism, but they can give rise to diabetic ketoacidosis in various serious or stress settings. So let us come to the American Diabetes Association 2021 guidelines. Now, the group 1 has been modified. Now, where ASCVD predominates, like an established ASCVD, indicators of a high ASCVD risk, like age more than 55 years, with a coronary carotid or a lower extremity artery stenosis more than 50%, or a left ventricular hypertrophy. The drugs of choice include either a GLP-1 receptor agonist or an SGLT2 inhibitor. Now, where a heart failure or a chronic kidney disease predominates, like particularly an ejection fraction less than 45%, a chronic kidney disease, specifically an EGFR between 30 to 60 ml per minute, or a urine albumin creatinine ratio more than 300 milligrams per gram of creatinine, the drug of choice after metformin becomes hands down an SGLT2 inhibitor with evidence of reducing heart failure or a chronic kidney disease progression in various cardiovascular outcome trials if the EGFR is adequate, or if the SGLT2 inhibitor is not tolerated or contraindicated, or if the EGFR is less than adequate, especially now less than 30 ml per minute, add a GLP-1 receptor agonist with a proven cardiovascular disease benefit. All these modifications have happened now because of the Credence trial of canagliflozin and the Darpa CKD trial of dapagliflozin, and also the Darpa Hf trial of dapagliflozin. So great drugs to be used for delaying the progression of chronic kidney disease and also improving heart failure outcomes for your patients with type 2 diabetes. Group 2 remains same, especially where cost is a major issue, especially in our country like India. Use either sulfonylurea, especially modern sulfonylureas like glyclazide extended release or a glimepiride, or a glitazone like a pioglitazone. Now, recommendations for antihypertensive treatment for confirmed hypertension in people with diabetes. Now, initial blood pressure more than 140 by 90 and less than 160 by 100 millimeters of mercury. Lifestyle management, or start one agent. Now, if there is no albuminuria or a coronary artery disease, start one drug like an ACE, ARB, calcium channel blocker, or a diuretic. If there is presence of an albuminuria or a CAD, start either with an ACE or an ARB. Initial blood pressure more than 160 by 100 millimeters of mercury, lifestyle management, and start two agents. If there is no albuminuria or a coronary artery disease, start drugs from two or three options like an ACE, ARB, a calcium channel blocker, or a diuretic. If there is presence of an albuminuria or a CAD, ACE or an ARB, and a calcium channel blocker or a diuretic combination. Assess blood pressure control and side effects of your patients. So what we have learned in 2020, especially for cardiovascular outcomes, and we come to the landmark BRACE Corona trial, which was presented in the European Society of Cardiology digital experience in the end of August last year by Dr. Renato Lopez, who presented, or who was the lead presenter of the Augustus trial of Apixaban. So the BRACE Corona trial was continuing versus suspending angiotensin converting enzyme inhibitors and angiotensin receptor blockers, or ACE ARBs, and their impact on adverse outcomes in hospitalized patients with a severe acute respiratory distress syndrome, coronavirus 2, or a SARS-CoV-2. And this was one of the major problems which a lot of patients or even healthcare providers in last year's webcast had asked me whether to continue drugs like ACE, ARBs. Patients do not know the technical terms of these drugs, but they were very cautious whether to continue using antihypertensive drugs in SARS-CoV-2 infection. And the BRACE Corona trial answers this question very elegantly. So there is an equipoise on the effects of RAS inhibition in COVID-19 infection. So the hypothesis one was that RAS inhibition is harmful for your patient. ACE and ARB could increase an ACE2 receptor expression and thus enhance viral binding and viral entry, leading to worst outcomes in patients with a COVID-19 infection. Hypothesis 2 was RAS inhibition is protective for your patient. Now, diminishing production of an angiotensin 2 with either an ACE or an ARB enhances the generation of angiotensin, which attenuates inflammation and fibrosis and therefore could attenuate lung injury. The BRACE Corona trial was a multi-center phase 4 randomized clinical trial involving 659 patients. The trial included two arms, either temporarily suspending ACE or an ARB treatment for 30 days or continuing to use an ACE ARB treatment. Inclusion was patients aged more than 80 years, hospitalized with a confirmed diagnosis of a COVID-19 infection and a chronic use of an ACE or ARB. Exclusion criterion was hospitalization due to decompensated heart failure in the last 1 year, use of more than 3 antihypertensive drugs, use of drugs like Arnis or sacubitril valsartan, or what they are popularly called Entresto by Novartis in the United States and Vimada in India. Hemodynamic instability in the first 24 hours until the moment of confirmed diagnosis of a COVID-19 infection. The primary outcome was days alive and out of the hospital at 30 days. Let us see the primary outcome of the BRACE Corona trial. Here you can see both the Kaplan-Meier curves of either continuing or suspending ACE or an ARB therapy, with a mean difference of 1.1 days between the two Kaplan-Meier curves, with a mean ratio of 0.95. So it didn't matter whether you either continued or suspended the use of an ACE ARB for patients who were hospitalized with a mild to moderate COVID-19 infection. So clinical status at 30 days, suspending an ACE ARB alive and out of the hospital at 30 days was 91.8%. Continuing an ACE ARB alive and out of the hospital at 30 days was 95%. So the BRACE Corona trial provides a randomized trial evidence showing that suspending ACE or an ARB therapy for 30 days did not impact the number of days alive and out of the hospital. Because these data indicate that there is no clinical benefit from routinely suspending these medications in hospitalized patients with mild to moderate COVID-19 infection, they should be generally continued for those with an indication. There was also a very elegant publication in December of last year called as the Replace Corona Trial. Replace Corona Trial was a large US-based claims database for using either an ACE ARB in patients with a COVID-19 infection. There were a large number of patients who were included in this Replace Corona Trial, and the conclusion of this trial was that an ACE or an ARB therapy did not increase a COVID-19 infection for your patients with or without diabetes, but with hypertension. So a Brace Corona trial or the Replace Corona trial, stamp the authority of using a ACRB therapy for your patients with hypertension with a mild to moderate COVID-19 infection. Let us see something very interesting, and that is the Darpa HF trial or dapagliflozin in patients with heart failure and a reduced ejection fraction. The Darpa HF trial was initially presented in 2019 in the European Society of Cardiology and subsequently in EASD of Barcelona. Now, Darpa HF trial was a phase 3 placebo-controlled trial, including 4,744 patients, a duration of 18.2 months, NYHA class 2, 3, or 4 heart failure, and an ejection fraction of 40% or less to receive either dapagliflozin at a dose of 10 milligrams once daily or placebo, in addition to recommended therapy. Now, the outcome was composite of worsening heart failure like hospitalization or an urgent visit resulting in intravenous therapy for heart failure or cardiovascular death. Now, these are the various outcomes of the Darpa HF trial: a significant reduction in the primary composite outcome by 26%, a significant reduction in death from cardiovascular causes by 18%, a significant reduction from death from any cause by 17%. So among patients with heart failure and a reduced ejection fraction, those who received an SGLT2 inhibitor, dapagliflozin, had a lower risk of worsening heart failure or death from cardiovascular causes and better symptom scores regardless of the presence or absence of diabetes. Now, the Darpa HF trial was again presented in two parts. The diabetes cohort was presented in ESC by Professor Don McMurray, and the non-diabetic cohort was presented in AHA of 2019, again by Professor John McMurray and by Dr. Mikhail Kosiborod from the Mid-America Institute in USA. So the trial was in two parts, with and without diabetes, and also with or without the presence of angiotensin receptor neprilysin inhibitors or ARNIs. Now, it didn't matter whether ARNIs were used or they were not used in the Darpa HF trial. Now, these results of the primary and secondary composite outcomes of the Darpa HF trial were independent of the usage of ARNIs, and they were absolutely on the usage of dapagliflozin 10 milligrams per day. So let us see something very interesting, a comparison between the Darpa HF trial and the EMPEROR-reduced trial, which was presented last year in the European Society of Cardiology Digital Experience and subsequently in EASD Virtual Experience of 2020. There is a lot of queries and misunderstandings between the Darpa HF trial and the EMPEROR-reduced trial. Which is better than the other, or both are the same? So this slide answered that question. Now, a hospitalization for heart failure reduction was almost similar between the two trials, 30 to 31%. Cardiovascular death reduction was significantly greater by 18% in the Darpa HF trial as compared to 8% in the EMPEROR-reduced trial of empagliflozin. All-cause death reduction was significantly greater by 17% in the Darpa HF trial versus 8% in the EMPEROR-reduced trial. Onset of new diabetes in pre-diabetic population reduction was again significantly greater by 32% in the Darpa HF trial versus only 14% in the EMPEROR-reduced trial. Ejection fraction Now, benefits are consistent across the spectrum of baseline left ventricular ejection fraction in the Darpa HF trial versus 30 to 40% ejection fraction, no benefit seen in the EMPEROR-reduced trial. A change in quality of life score on KCCQ, or the Kansas City Cardiomyopathy Questionnaire, a difference of 2.8 points in the Darpa HF trial versus 1.7 points in the EMPEROR-reduced trial. Renal endpoints, 29% non-significant renal death was included in the Darpa HF trial. 50% significant renal death was excluded in the EMPEROR-reduced trial. Some more staggering differences and similarities between the Darpa HF and the EMPEROR-reduced trial. Both trials had significantly elevated NT-proB and P levels, but the EMPEROR-reduced trial had more sicker patients with heart failure with an average left ventricular ejection fraction less than 30% as compared to 40% in the Darpa HF trial. But both the trials gave rise to significant reduction in hospitalization for heart failure, cardiovascular death reduction, all-cause death reduction, but numbers speak for themselves. The Darpa HF trial was significantly better as compared to the cardiovascular death reduction, all-cause death reduction, onset of new diabetes in the pre-diabetic population reduction. So dapagliflozin in the Darpa HF trial, especially on the quality of life scoring on the Kansas City Cardiomyopathy Questionnaire, was significantly better as compared to empagliflozin in the EMPEROR-reduced trial. Let's come to vitamin D and cardiovascular disease. Is vitamin D important for your patients, with type 2 diabetes? This was a presentation in ADA of last year. Now, the authors identified 1,335 diabetic patients from the Department of Endocrinology, Shanghai 10th People's Hospital from 1st November 2017 to 2 November 2019. 603 type 2 diabetic patients were included in this cross-sectional study. The participants were divided into two groups depending on the ankle brachial pulse wave velocity less than or more than 1,700 centimeters per second. A linear correlationship was used to evaluate the relationship between 25-hydroxy vitamin D and the ankle brachial pulse wave velocity. Now, there was a negative relationship between 25-hydroxy vitamin D and arterial stiffness, which was assessed by the ankle brachial pulse wave velocity. Now, high 25-hydroxy vitamin D was found to be a protective factor for arterial stiffness in patients with type 2 diabetes. So you should encourage of using vitamin D for your patients with a cardiovascular disease, and especially during these times of COVID-19. Let's come to something very interesting for your patients with diabetes or novel oral anticoagulants. Now, this was a meta-analysis or a retrospective study, a comparative effectiveness and safety of DOACs versus warfarin in the UK patients with atrial fibrillation and type 2 diabetes. This was a publication of December 2020. Now, a retrospective cohort study which was designed using the UK clinical practice research data link between August 2011 to June 2018. A total of more than 8,500 participants were included, with 1 year naive users of direct oral anticoagulants or warfarin, followed from the date of first prescription of an oral anticoagulant until the end of the study period. Death, discontinuation of treatment, switching to another anticoagulant, or an outcome of interest, whichever came first. So DOACs or NOACs like apixaban or rivaroxaban or dabigatran are effective and safe alternatives to warfarin for the prevention of stroke in atrial fibrillation and type 2 diabetes, and the effectiveness and safety is irrespective of the diabetes severity. And I'll tell you something very interesting which has happened in JACC, or the Journal of the American College of Cardiology, of the 9th February issue before I end. So NOACs like rivaroxaban or dabigatran should be used for your patients either with a non-valvular atrial fibrillation, a pulmonary embolism, or a deep vein thrombosis, and now with new indications like a coronary artery disease or a peripheral vascular disease, which is very much indicated for the usage of rivaroxaban. So we come to the most important presentation of rivaroxaban, or the COMPASS diabetes trial, which was presented last year in the American College of Cardiology virtual experience of March for vascular protection in patients with diabetes. The COMPASS diabetes trial was one of the trials of the COMPASS program of rivaroxaban. Now, the COMPASS diabetes trial showed the effects in patients with diabetes at baseline versus without diabetes. Close to around 7,000 patients with diabetes versus more than 11,000 patients without diabetes. Patients were randomized to rivaroxaban 2.5 milligrams plus aspirin 75 to 100 milligrams versus placebo plus aspirin. The primary efficacy was cardiovascular death, myocardial infarction, and stroke. The secondary composite endpoints was all-cause mortality, cardiovascular death, myocardial infarction, stroke, including amputations. So let us see the primary and secondary endpoints of the COMPASS diabetes trial. Significant reduction in cardiovascular death, myocardial infarction, or stroke by 26% in patients with diabetes versus 23% in patients without diabetes. Significant reduction in all-cause death by 19% in patients with diabetes and 16% in patients without diabetes. Let's see the secondary composite endpoints of the COMPASS diabetes trial. Significant reduction in the composite of cardiovascular death, myocardial infarction, stroke, or major vascular amputations by 27% in patients with diabetes and 26% in patients without diabetes. So rivaroxaban should be used in your patients with diabetes for reduction of vascular complications and reducing vascular amputations. This is the entire analysis of the COMPASS diabetes trial. Now, the benefits in diabetes with or without prior ischemic events, prior revascularization, or prior composite of ischemic events and revascularization, whether they were present or absent, did not matter. There was a significant reduction with rivaroxaban in patients with diabetes as compared to patients without diabetes. Both the cohorts or both the groups with and without diabetes showed significant reduction, which you have seen in the previous slide, but more benefits were seen in patients with diabetes. There was a significant reduction in the hazard ratios for prior ischemic events by 0.76 and 0.73%. So a 26% and a 27% reduction in ischemic events by the usage of rivaroxaban. Now, something also very interesting has happened in the 9th February publication of JACC, and that is a secondary analysis of the COMPASS trial, which has been published. And this trial on the secondary analysis of rivaroxaban of the COMPASS trial showed that the benefits has been seen across BMI groups in patients with an atherosclerotic cardiovascular disease. So it didn't matters now whether you have a high BMI or a lower BMI. The benefits or the net benefits of rivaroxaban will be seen across the body mass indexes. So rivaroxaban is very much a drug for your patients with diabetes to lower the ischemic events, vascular events, including amputations, and especially CLIs or critical limb ischemias, which is very elegantly seen in the Voyager PAD trial of rivaroxaban, which was presented last year by Dr. Mark Bonacca in the European Society of Cardiology, and it was also present in Viva, a virtual experience of 2020. Post-hoc analysis of the Voyager PAD trial was also presented in the American Heart Association virtual experience. And recently, a post-hoc analysis of the Voyager PAD trial was presented just last month's link or the Leipzig interventional course in Leipzig, Germany. So rivaroxaban is very much there for your patients with diabetes. And before I end and summarize, Risk of cardiovascular disease, comorbidities in type 2 diabetes has remained a significant and relatively unaddressed challenge over the years. Global guidelines has evolved and recommend the preferential use of agents with cardiovascular renal benefits in patients with type 2 diabetes. The Brace Corona trial provides randomized trial evidence showing that suspending ACE or ARB therapy for 30 days did not impact the number of days alive or out of the hospital. SGLT2 inhibitors, especially dapagliflozin, could be considered in patients for proven cardiovascular benefits and safety, respectively. High 25 hydroxy vitamin D was found to be a protective factor for arterial stiffness in patients with type 2 diabetes. Real life data on the effectiveness and safety of novel oral anticoagulants show that NOACs or DOACs are effective and safe alternatives to warfarin for the prevention of stroke and atrial fibrillation with type 2 diabetes, and the effectiveness and safety is irrespective to the diabetes severity. And finally, a low dose rivaroxaban 2.5 milligrams plus aspirin 75 to 100 milligrams reduces major cardiovascular events in stable atherosclerosis, irrespective of the presence or absence of diabetes, which has been very elegantly shown in the COMPASS diabetes trial. Though the absolute reduction were numerically larger in patients with diabetes, including for all-cause mortality, the net clinical benefits when examining the irreversible outcomes appeared numerically greater in those in patients with diabetes. With that, I will end, ladies and gentlemen. Thank you very much for your patient listening, and I hope it was informative for you in this evening Facebook Live with USV Pharmaceuticals. Thank you very much. Himanshu, is there any queries, questions, or we can end today's Facebook Live? Hello, Himanshu, can you hear?
So we can wrap.
We can?
Wrap.
All right. Thank you very much, and a good evening to everybody.